I'm going to talk about capsular contracture and our study. It was published. Was it this or the last year? I can't remember because time is really flying. But anyway, I think capsular contracture. It was the biggest problem with breast augmentation. It was something. Well, I didn't know it by then, but it was something like 5 or 6%. We had capsular contracture. And breast augmentation, it was a very good operation, and we had the problem, and then I wanted to get rid of the problem. Here you can see on the left side the typical case with capsular contracture. I think you have seen this. So it's like round implant, but it's not round. It's 350 cc round staple implant with capsular contracture. And on the other side, so it's after capsulectomy, and then we changed the implant to 440 cc. So anyway, a breast with capsular contracture, so it's ugly. It's really unesthetic. It's really hard. It can be like having a baseball within the breast, and painful. So it's around 6 years ago when I was thinking about this, how to get rid of this problem, and there were some reports or studies of bacteria found in the capsules, and then I read Adam's trials with triple antibiotic treatments, and then I decided now we really have to take care of this problem, get rid of this. And the basic principle, when you look at, I will show you what we started to use, our antibiotics, so it was really get it done, kill them all. I mean the bacteria, not the patients. So this really really worked, but now what I think is that maybe less works as well, so we don't need all this stuff we have used. This was published online this year, and you can find it from net. So as you know, the rate of capsular contracture is something like something between 1 and 30%, and there are studies which show that almost all of them. So you can see or notice or find them within 12 months after surgery. And now what we did was, I've been doing breast augmentation more than 20 years, and we had the protocol that I think it was very common in Finland, and then we changed. So in group A we had 165 patients, and group B 165 patients. Group A, so we had it's just next slide. Anyway, I did all the operation we used. It was in the beginning it was Magan, then the factory was sold, it became Allergan, and then it was sold again, and then it was Naturel, but it's the same implant, 410 or 510 form stable implants. Here's still a Baker classification, so 1, 2, 3, 4. So number 4 is you have really severe contracture. So we counted 3 and 4. So anyway, in group A, the Finnish way of giving antibiotics was 1.5 gram of, usually it was Cinasef IV just before the operation, and Cefalexin 750 milligrams twice a day for a week. This is how it was, and then we changed. So how we came to this protocol? So before we had 1.5 grams of Cinasef, it was usually Cinasef. So we gave only 750 milligrams IV, and then we had for the irrigation we had the other half 750 milligrams plus gentamicin plus betadine, so it was a triple treatment. And instead of cefalexin after the operation, we had levofloxacin 500 milligrams. And it used to be for 10 days. Why 10 days? Because 10 is more than 7 days. So I told you I really wanted to get rid of this problem. So this is what we did. I will tell you what we do nowadays. So here you see the implant, there's betadine and the antibiotics, and then I always still clean the wound edges with this solution, and then we what is left, so we just put it in the pocket, and I always use drains, and they are the medication we use. Always drains. So now in group A and group B, so most women who come for breast augmentation, they are something like 34, 35 years old, usually very healthy. So the mean follow-up with this study was almost 2 years. And I think the mean implant size, it's a little bit smaller than in Sweden. In Sweden it was 325 or something. And most of the implants, they were natural Omega 410. And then when we look at the results, so in group A, so we had capsular contracture in 10 cases, that's about 6%. And in group B, only one. There was superficial wound infection 3 and 2, seroma 3 and 2, hematoma 1 and 2, so anyway there was no implant explantation. So the rate of capsular contracture, it was very, very significant difference. And in group A, so the capsular contracture, when we noticed it, it was usually 17 months after the operation, and a little bit later, the only one in group B, it was almost 2 years later. So our conclusion was that the use of topical antibiotics, it seems to help. So we got rid of capsular contraction. And then what's the reason? So we thought that maybe it's the biofilm, and there was Dr. Wikström was talking about this Tambotos study. Now our follow-up time is quite short. Now we have been doing this for 5 years, and the patients, they can come to me for free if they have any trouble, if they have any troubles with their breast. So most likely they don't go to other places where they are charged. They come to me. But so it's quite short. But from previous studies, you know that most of the contractures you can see within the first year. So by now we have used this treatment. So we have more than 500 women, more than 1,000 implants, and I think antibiotics we used, it was quite a lot. So we have reduced. I reduced first the levofloxacin dose from 10 to 5 days, and then we go on with that maybe half a year. Now I have reduced it from 5 to 2.5 days. And I think I can leave it completely, but I have to reduce this, this treatment step by step, so I know that what's happening. And among these 1,000 implants, so now we have had 3 capsular contractures, And what is interesting is that we noticed one after mastitis, and two most likely after dental problems, maybe 2 years after the breast operation. So 3 out of 1,000. And if you really are pushing the patient and asking, did you have any infection? So I think most likely you are going to find something. This mastitis, so she was treated by me, so it's her and 2 others, so most likely dental problems. And after that, capsular contraction. So, what is the trouble with this biofilm hypothesis is that now when you look at studies, you know that it's if you have a biofilm, it's very hard to find this bacteria. But most of the studies show at least 50% of the capsules, I don't know if you can call it biofilm, so you can't find anything, however you try to look for it. And and what we did, so we have taken these capsules and tried to do this DNA analysis to find any trace of bacteria. Now we have had 4 patients. We have did this 4 times, and these guys who do this study, they should be experts in Turku, University of Turku, though we haven't found anything. So I have been wondering why, so I don't know, I think Dr. Wikström can enlighten me. But when you think about biofilm, so I would think it's like a slime full of bacteria, and if you do a DNA analysis, you should find something, but not a trace. I don't know. So this in mind, I found a paper this spring, and I don't know if you have heard of TLR, as we say it in Finland. Toll-like receptors, or pattern recognizing receptors. And I must tell you, I read this paper. It was in press. I think it's published by now, so it's already published. But I read it in May, and it was like rocket science to me. And then I read it again after holiday. And this is speculation, but I think this could explain this, at least part of these capsules we get. So anyway, toll-like receptors, you can find them in different white cells, and they are activated by bacteria. And the TL receptors, they are like gatekeepers to the body. When you get the infection of bacteria, so they recognize the bacteria and they start this healing process, inflammation and so on. It's coming after that. And if you have a acute injury, so the result is normal wound, normal scarring. But if you have chronic injury, so what you get is fibrosis. This has been proved, liver cirrhosis. So there seems to be always bacteria. In kidneys, there are bacteria. You get kidneys fibrosis, lung fibrosis. Also in a lung, you can find bacteria. So it seems to be so that you need bacteria and like chronic injury, and then these receptors start fibrosis, and it goes on and on. I don't know if it's so or not, but at least this could explain that why we can't find any bacteria from the capsules. So here's a diagram. If you have acute injury, so you have tissue repair, inflammation, and normal scarring. And if you have chronic injury, so you have fibrosis and abnormal scarring. If someone wants, so I have the paper here that you can have a copy. So, still one thing. now we have this problem of double capsules. And I have been thinking what could be the reason for the double capsules. I haven't heard that anyone has found any bacteria. But maybe if physical stress is like a chronic injury, it could explain these double capsules by this TLR activation and fibrosis. And I think, we have in 1,000, we have only three patients with capsular contracture, and it seems to be so that they have had some kind of fulminant infection. So maybe we should think about this a little bit more. Maybe our patients have to be informed that maybe they need antibiotics to prevent capsular contracture. Okay, here's the paper. Thank you.